How do you do that? Here we go. You should be able to see me and the slide. Yeah. So thank you, Ayman, for the introduction. Thanks also to MCI and Siegfried in particular for organizing this series. As you rightly pointed out, the work that I present today, it's part of a special issue that was led by VheP indeed, and with many of us scattered around the world, including yourself, Ayman, and others. Yeah, definitely led by Naomi Moy and Duan Lee from the University of Newcastle, and our Jonathan Treater, UK Norwegian connection. I put here some of the links on the issue itself, and how you can follow our group and our activities. Pretty much we can jump onto the presentation of today. So this paper really, it's with a number of colleagues based in Latin America and Australia, I would say, mostly from Chile, Brazil, and Australia. Myself, I'm an author. I'm connected to Latin America because of work mainly in Colombia and Chile in my previous life. We decided to engage with local people to have a better understanding of what actually responding to COVID-19 in those countries. So we focused on these five countries, and my presentation will mainly be around the response to the pandemic so far. Pandemic that seemed to be in the way of improving until very recent days or weeks, and now I think the numbers are suggesting rather bad news in a sense. But the countries are Peru, Ecuador, Colombia, Brazil, and Chile. So what is it we did in this paper? We looked at the pre-pandemic context, and we looked at the mitigation and containment measures that followed if immediately from the early days of the pandemic. And also we tried to look at the comprehensive response from an economic, technology, policy perspective in general in all these countries, and try to find in particular aspects of convergence that were meaningful to the local characteristics. Of course, Latin America is a bit of a funny term because it's in part in South America, part is Central America. Obviously, some of the characteristics of the countries are very different. Some, in fact, that we didn't include, like Uruguay, has managed very well, and some claim it's because of its geographical nature. Some other claim because it's of its actual decisions. Obviously, all these factors that are demographic, geographical, and so on, and socioeconomic are, of course, a big component of the success or failure of some of the measures introduced, together with actually with the actual structure and nature of the systems there. Um, how did we do the analysis? Of course, it was based on live documentary analytics of all the policies from federal to regional that were introduced and have been introduced so far since January 2020. So the first important dimensions that I would like us to focus on today is that these countries share some important characteristic. Clearly, they have an important informal sector, which is different from what we have observed in the so-called developed world, in that individuals really need to engage in activities that have a strong physical daily mobility element to really get by. In fact, the poverty rates, also the HDI indexes, are lower compared to OECD countries, and that is also reflected in general public health and articulation of sanitations. And here you can see that these are the key indicators that really show an important picture in the context of understanding the impact of policy and technology in countries that do have this kind of socioeconomic context. And obviously, this is possible to extrapolate also for other countries in the developing spectrum that are not in the region. Together with that, of course, the supply side in these countries have been historically in healthcare very much depicting the classic developing picture, which is a picture that shows often a clear baseline or default public health sector that because of the scarcity of funding has to basically offer very little for a lot of people. You can see from these descriptions here in this chart that most of the systems have a public sector that supposedly covers all of the people, but in fact the private sector is the one that has a better capacity, better assistance in terms of doctors, nurses, and fundamentally also better service quality provision. But that's for very few individuals compared to OECD. Clearly, another important element it's related to the underlying risk profiles of the population. And here the picture is also more complex or incredibly interesting because you have fundamentally a number of things happening. One is the emerging and growing chronicity aspects, and also some of the elements that develop typically in countries that are OECD, such as obesity and the related conditions that emerge from that risk factors, but also risk factors that are more related to countries that are in development, so more related to contagious diseases and airborne diseases. So you have a complex public health and epidemiological picture to look at compared to OECD in a context where aging is clearly on the rise. So what are the characteristics of the response in these 5 countries? Certainly, they all reacted very fast and with European-style responses, both in terms of mitigation and in terms of economic support. Also in terms of restriction, the reactions was quite strong. And of course, one element that we need to look at when we look at these dimensions is also the compliance. And that is very much related to the characteristics and the underlying characteristics from a socioeconomic perspective. And the informality element, of course, plays an important role because that is what drives people to move and maybe not comply. So that is important to think about. And thirdly, it's also what happened in terms of the health system response, given that the public health capacity was quite limited, and how that has been compensated, if any, at all, for. So first of all, we noticed that immediately once the pandemic occurred in Italy, the reaction, you might recall, that was late Feb, begin March. The reaction in most of these countries have been immediate, even without many confirmed local cases. So the timing, one might say, and the stringency also of the measures has been strong and rapid, almost immediately. These are some of the responses based on the actual cases, and you can see how they relate to stringency. And you can also notice that despite this stringency, actually, they didn't do much in terms of containment of cases, perhaps except of Chile in the beginning. Then the second important element is what has been our consideration in terms of the comprehensive timing of these measures. Obviously, we can see that because of other underlying reasons, that we start understanding and seeing a picture where this stringency and the cases going up show that the timing of these measures was, in fact, too early, if anything. Now, because of the underlying informality issues and diffuse poverty in these countries for large sectors of the population, we have observed, in fact, that compliance with the stringency measures has been quite low. As you see from these two reports, in fact, mobility has been mostly respected, or mobility restriction has been mostly respected in the higher income brackets, which clearly has made things worse as the pandemic developed in Latin America. Obviously, there is an element here of communication and public pandemic management, which has been quite contradictory from a perspective of communication, as I said. In particular, if we think about federal and local management, it's clear that in some countries, in particular in Brazil, there is a trust issue in terms of what to do with the information that is conveyed by the central authorities in particular. So the other important element here that we need to consider when evaluating the responses to the pandemic is actually what happened in terms of healthcare system response. And this is unprecedented, really, in terms of public health system capacity, which is clearly something that will last in the future. All the countries have responded to this pandemic very strongly. Perhaps Brazil is the one that has the least strong response, but really upscaling the resources in an incredible way. So now, when we consider the other elements that you need to actually be able to respond to the pandemic, the picture on testing and tracing has been dramatically improved. In the beginning, these were incredibly difficult areas on which to intervene. So to conclude, it's pretty clear that the strictness of measures and the policy import that occurred and happened in these 5 Latin American countries when COVID first arrived has been very diligent, including extremely harsh measures of lockdown and curfews. Obviously, these measures, for a number of fragility of the healthcare systems, lack of investments, and clearly the issue of inequality and disparities, not only regionals, but also in terms of income, has meant that the effectiveness of these measures, despite their strictness, has been quite modest. In fact, over time, the relaxation of this measure has been coming in, and now the discussions are similar to what we experience also in Europe, in the sense that the lockdowns appear to be more and more dynamic. Of course, this is very susceptible to political, let's say, influence and also desire. And we have seen also in recent days in Europe that governments that had dynamic restrictions or lockdowns are now going into harsher forms of control, like Germany. Clearly, what we have learned is that the system response, despite the very limited capacity that has been a chronic problem for these countries, has now reached a better ability to respond, which will last beyond the pandemic. Clearly, so we have to think about this in terms of our policy implication going forward, and also for future pandemic. The nature of informality in the economy is very important for any economic policy and support policy to have an effect. This is true not only for Latin America, but it will be very true also for some parts of the OECD, where informal sectors are stronger. Clearly, income support need to take that into account if you want to have compliance with any form of restriction. I conclude now. Please follow us, as Ayman has indicated. We have a lot of information here on this link. Happy also to participate in the later debate, and now I stop sharing. Thank you, Ayman.
Thank you so much, Francesco, for those important insights on Latin America. I now invite Dr. Tan to share his presentation, which is about trends or mega trends in China post-COVID-19. Dr. Tan, please.
Thanks, Ayman. Can you hear me?
Yes.
Can you see the screen I share? Okay, excellent. Thank you. First, I'd like to probably make apology because my presentation will be moving away a little bit from the theme of this webinar, which is, as I understand, the direct response to pandemic in China. And also, I need to apologize because I'm not, by no means I'm an expert in health economics like Francisco, or health policy. But having said that, I think, as we all know, this pandemic has huge impacts on almost every aspects of our life, on the economy, on the society, on the geopolitics at a global level. So what I'm going to present over the next 10 minutes is to basically outline what I call 3 megatrends in post-pandemic China, based on my own observations. Like other countries, China, the impact of the pandemic on China is enormous. So here I just like to pick up three trends which has been accelerated or emergent since the pandemic. Of course, all those trends probably already had signs before the pandemic, but as I see it, the pandemic certainly accelerated those trends, and to some extent lock the country, lock China into those trends. The first trend is relating to what they call dual circulation. I don't know if you have come across this term, but this is at the center of the recent economic policy in China. Basically, the dual circulation refers to the two circulation. One is the internal circulation, which refers to the the domestic cycle of production, distribution, and consumption, in addition to the so-called external circulation. And external circulation basically refers to the process where China imports lots of raw materials, for example, from Australia, iron ore, coal, and then doing the manufacturing in the country, and then exporting goods to the rest of the world. And this is the model that has supported the economic development of the country during the past 40 years. But with the pandemic, of course, we all know that the risk and the vulnerabilities in this trade integration. And obviously many countries are working to reduce their reliance on other economies. And of course, this poses a huge challenges to China's economy and beyond. So as a response, China now developed this so-called dual circulation strategy, in particularly placing increasing emphasis on the domestic market, which is huge. So the intention is to tap into the domestic market. And that's the first megatrend, which I think will further develop over the next years, thanks to the pandemic. The second megatrend in China is relating to its low carbon transition. So my own research is actually on this very topic, the energy transition, particularly in China and its implication. And what we have observed is that the climate actions have recently certainly speed up. So in this September, in the United Nations General Assembly meeting, the Chinese President Xi Jinping has surprised many by announcing that China will committing to the carbon neutrality by 2060. It sounds like far away from now, but think about the goal of the European Union, which is to achieve carbon neutrality by 2050. And in the situation of the European Union as a whole already reached the carbon peak in 1990. So that's 30 years ago. And so for European Union to achieve a carbon neutral is relatively a natural process. It's just a extension of the current trend. But for China, you will see a very deep curve because China is yet to peak its carbon emission. And China is right now the largest energy user and the largest carbon emitter in the world. So you can see that the challenge is huge. And beyond that, just last week, China made an even more ambitious announcement about their renewed climate targets, which has raised from its targets as a part of the Paris Agreement. So last week, all the targets have been lifted up, which is again surprising to many observers. And you just think about the challenge of these targets, because these targets, those goals are not really just about the energy sector, not just about the energy system, but actually will have implication to the whole economy. Because, for example, in order to achieve carbon neutrality, for example, all the coal-fired station in China has to be phased out over the next 20, 30 years. And the road transportation has to be relying on electric vehicles or green hydrogen. And not to mention the manufacturing sector. So China is in many industries the largest producer. It's the largest producer of steel, cement, chemical, and so on. So all those manufacturings have to be either the production level has to be significantly reduced, or have to be powered by green energy. So the challenge is huge. And then the question is that why China is making such a move, and what is to do with the pandemic. So as my co-author and I recently commented in an article, we believe that this is to some extent to do with the pandemic, because all those announcements actually not just the climate strategy, but it is an international political strategy. As we know, during the pandemic, the international relations between China and the West has been deteriorating very, very substantially. In a way, I'm based, like Francisco, I'm based in Australia, so we see these kind of news every day in terms of the bad relationship between the trade wars between Australia and China, and that happened between China and some major developed countries as well. So in that regard, we believe it's probably makes sense that China makes such a move in order to gain some international support, because climate actions are a priority in the agenda of some countries and a group of political groups. So I think, of course, to make this group, there are multiple considerations. It's good for China, um, uh, for its local environment, for its industry development. But we are saying that it's also part of the, part of the consideration is also to do with to repair the international relationship, to gain international support. Um, uh, so again, I'm trying to relate this meg trend to the pandemic, and I do see there's some element of a connection here. And finally, the last meg trend is the economic model of China. China has traditionally seen as a development state. So by development state, this is a term in political science. Basically, it's not just China, but many East Asian countries have been classified as development states, and those countries traditionally, in those countries, a state play a very critical role in the economic development, like Japan, like Korea, like Taiwan. And there are two pillars in this development state approach. One is the use of extensive industry policy to build and to promote industries. And another is a very significant, very critical role of state-owned enterprises play in economic affairs. So that has been, a kind of, established view on China. But it's probably less known that in China also it's very popular. The for the market-based approach is very popular among political elites, business community, and academics. So during the past 30, 40 years, it's basically there's a internal struggle, internal fight between those two approaches towards economic development. But now we have the pandemic, and we have seen different responses to the pandemic in different countries. And the narrative in China by the ruling party is that China is doing very well in terms of its response to the pandemic, precisely because it's state-led approach. So this narrative has been put forward as a justification to its governance system, and most specifically, its state-led approach in predominantly in economic development, but also you can argue that in other areas, for example, political and social affairs. Of course, that started from the global financial crisis, and at the time, the market liberalism has been challenged, especially in the context of China. China pointed to what happened in the U.S. and in the Europe to see that you basically screw up your economic system, and the ruling party is arguing that it's because we have such a state-led approach. We had such a governance system, so that put China in a different position. So I suspect that after the pandemic, in the post-pandemic China, this argument will be even developed fuller. So as a result, the role of state-owned enterprises and industry policies will be used more substantial in its economic policy and in its economic development in general. So that's pretty much my presentation. And again, I'm sorry, I probably didn't really present what you have expected as in terms of on the direct response of China to pandemic. But I hope the presentation will add a little bit value to this webinar. Thank you very much.
Thank you, Dr. Tan. Indeed, it added new insights. Thank you so much. And yeah, I'm sure that those trends will intersect in the future with health outcomes and health organization, health economics in the future. Thank you so much. And now I invite Dr. Ridwan Ibrahim to present the case of Nigeria. Dr. Ridwan, can you please share your screen?
Okay. Good morning.
Good morning. Dr. Ridwan, we cannot see your presentation. Dr. Ridwan? Okay, Dr. Ridwan signed out. So I think we can continue with Ayman Sabah. Ayman, are you ready?
Yeah, sure.
Please, go ahead.
Okay, let's go. So first of all, thank you very much for this very kind invitation and for the opportunity to speak to all of you. Now, I've been asked to present some aspects related to the way Egypt responded to COVID-19 in terms of its policies and in terms of the different positives and negatives in the way it actually managed its battle against the pandemic. The main challenge when presenting something like this is that, you know, as academics, we're kind of used to showing evidence using data that have been excessively analyzed and presented, and with a considerable degree of credibility. When we're presenting something that is as fresh and as still very in its early phases of research maturity, we're always confronted with this idea of either saying too little or, you know, always putting this, you know, asterisk at the end saying that this is just an analysis. So I just wanted to put this out there that in the end, lots of things are still on the move. So when we're tackling COVID response in Egypt, first let me give you a brief hint of how Egypt functions. So Egypt is considered by many as a lower middle income country. It has 100 million people as a population. It is the third most populous country in Africa. And when we look at the geography of the country, 8% of its land is actually occupied by people. So it's a pretty large country, but in the end, the population is highly dense around the Nile Valley. Of course, high density means a relatively overcrowded population, which is extremely relevant when we look at a pandemic that is of this character as COVID-19. The population itself has been going through a number of events that were happening in the last decade, which affected many things related to governance, related to the relationship between citizens and the state. And it has been going through a very radical pivotations, very radical shifts from a very outspoken society that was in the street speaking out, denouncing things that they didn't like, to a society that is very restricted in the way it allows itself to respond to government's policies. So with this also comes the burden of having to dig sometimes a bit deeper than needed in order to get data that are relatively accurate. Now, the Egyptian population is also relatively young, yet we have more than, it is estimated that a quarter of the population is hypertensive. We have 80% of high blood glucose. Obesity rates are very high, especially among women. In the latest survey by WHO, they have estimated that 48% of women suffer from a certain degree of obesity. And one of the most important health risk factor was hepatitis C, with the most modest estimations. We are talking about around 15% of the population in 2015. Recently, the government has been extremely responsive to that. The numbers have been dropping in the last couple of years, and now the country actually estimates that it is on the verge of saying that it has completely eradicated hepatitis C due to the production of new lines of treatment. Other risk factors like alcohol may not be as prevalent as in Europe, because around 95% of the population claim they complete absenteeism from alcohol consumption. But the rates of tobacco smoking and consumption is pretty high. 23% of the population is estimated to be consumers of tobacco products, which means that this increases the vulnerability to COVID-19. Now, there are some socioeconomic risk factors which are quite relevant to mention. Poverty rates, it is estimated that 30% of the population lives in some degree of poverty, which is also associated with overcrowded living and informal work, which is an additional risk, economic and health wise. Catastrophic health costs in Egypt are the primary cause of families sinking under the poverty line. And what we mean by catastrophic health costs in that case are conditions that affect the welfare of the entire family, not just individuals. When we look at healthcare coverage and how it functions, the official figures state that 58% of the population, or 59 almost, are actually insured. But this figure is very misleading because it does not necessarily reflect utilization rates. And when we look deeper at the latest demographic health survey, for example, we see that particular groups, women in specific, the utilization rates of health insurance services reaches 8% of the women insured, which means that 92% of insured women don't end up using their insurance entitlements. They're not benefiting from it, which is extremely serious because it outlines that we have the image or the structure of an insurance coverage, but it doesn't reach the main beneficiaries at the rate it should. And this is actually especially true when it comes to so these are the figures from the health insurance organization that estimate that in total they only have 1/5 of those insured actually using the services, and in the poorest quintile they are 14%. So actually the poorest people end up not using the services, not the richest one, which is extremely important because it's not only a reflection of quality of service, but in many cases it has to do with barriers to access the services in terms of bureaucratic or procedural barriers, sometimes geographic barriers, and most importantly, access to information on the services and the things that they are entitled to. Recently, this has been improving. There has been a shift towards universal health coverage, which was in Egypt, the landmark moment when this happened was in 2014, with a clear mentioning of the right to health as a right in the new Egyptian constitution, and a mandate to establish a comprehensive health insurance scheme. Now, this also translated in the realization of the Sustainable Development Goal in terms of achieving universal healthcare coverage. And then in Egypt's Sustainable Development Strategy for the year 2030, it has been clearly stated in the health component that among the 3 objectives they have is achieving universal healthcare coverage for all Egyptians and ensuring high quality services. So this has been the agenda for the healthcare system prior to COVID. Now, based on this, in 2019, they began to actually roll out the comprehensive health insurance schemes, starting from a set of specific areas in Egypt. And then the current or the state of the healthcare system resources at that time were, as stated by the available literature, a little bit below regional average, although in 2019, when we compared the actual figures given by the government, the number was significantly less in terms of hospital beds per 1,000 people in Egypt. And 37% of these beds are in the private sector. So the private sector, again, as mentioned by Dr. Francesco, the private sector in the context of developing countries in a way plays a considerable role in that. And this really outlines the kind of disparity that happens. And there is a significant shortage in medical staff, particularly nurses. This has to do with the working environment. It has to do with the compensation models. It has to do with the way the healthcare system is structured. Doctors prefer, in many cases, to work in other countries. Nurses, they don't see necessarily the benefit of having to go through nursing school. So we have a very limited number in that regard. These are the settings on which the COVID response was built. Now, moving forward, the health system response needed to cope with all of this. And frankly, as researchers in this sector, we were very afraid, because when you build a COVID response based on resources that are limited, an overcrowded population, and a healthcare system that is still in a transition, it can be very critical. The good thing, however, in that regard is that the Egyptian healthcare system has been built on its preventive component. So pandemic or epidemic controls, prevention, vaccination campaigns, outreach campaigns, this has been the cornerstone of the healthcare system, because Egypt, in its position, has been, in its geographical position, has been in the root of a number of epidemics and pandemics around its existence. So a considerable portion of the healthcare system is built on the preventive component. This is part of a cohort study that we carried out at the beginning of the pandemic, and it outlined that the level of worry among the population when it comes to COVID and how it would affect their livelihood. As you can see, there is an interesting dome that is happening when it comes to income levels, which has also been translated when we look at applying self-isolation that was mandated at the beginning of the pandemic response. As you can see, at some point you have a peak that is happening. So the more you earn, the more likely are you to apply self-isolation, because then you are at a less economic risk. But then this dome, at the last group, it actually goes down, simply because here we're shifting into the group of people who are owners of their own businesses. So they have more responsibilities and they have staff that they have to take care of. So they can't necessarily afford to apply self-isolation as much as other people from other income groups. The kind of reporting that has been available in Egypt, so we received this, this Facebook post. I'm supplying with a translation of it on daily basis by the Ministry of Health, social media platforms. Now, when I was preparing this presentation, I ended up really resisting the urge to show you trends and charts in terms of progression of the pandemic. And this is for a very specific reason. The validity and credibility of these numbers are extremely questionable. So first of all, they are questionable in the eyes of the government officials themselves, definitely in the eyes of the people, and they have absolutely, right now, at least in terms of the numbers of new cases, they have absolutely no relation with reality whatsoever. And I'm going to tell you why this is the case. But the thing is, there has been some commendable courses of action that has been taking place in Egypt's COVID response. First of all, we actually saw that the government has a plan. So the government developed a plan very early on, and it was a very tiered plan. And it said that if this happens, we're going to do this, and if this happens, we're going to do that. Of course, the plan wasn't necessarily, spread around the media in a file that people can read and, respond to, but the outline was there. And this was really something we're not used to having in that regard. The second point is that there was a relatively early action. Egypt began to respond to the pandemic with restrictions in airports, with measures to attend to the pandemic very early. And prior to receiving the first cases of COVID in Egypt, the Minister of Health actually flew to China to further understand things and have a real, understanding of what is going on and the kind of things that need to be done, which is a move that was heavily criticized by civil society back then as well. We have, for the very first time, seen a whole of government approach to health, which meant that we would see cabinet meetings with all of the ministers, all of the government working together in their response to COVID. We saw press conferences and events that were addressing the general public, which were presented jointly by different ministers, not only the Minister of Health. And this really marked a radical transition in the way we see response to such critical cases happening. The way resources and infrastructure were mobilized were quite innovative. In the very first phases of the pandemic, the protocol for management of the cases included hospitalization, not only for serious cases, but really for all cases, for all those who were tested positive. And the way they did that is that they actually turned university dorms, hotels, and accommodation facilities that are at the disposal of the government, youth hostels and such, into isolation hospitals, which are not necessarily hospitals, but they are government managed quarantine places. And if you were tested positive, you had to go there. They did not rely on the idea of home self-isolation among the family, because they understood the kind of overcrowdedness issue that would happen, and that this won't necessarily yield the results that is wanted. So there was a relative degree of intelligence in the way they managed the available resources, and that they mobilized, the infrastructure and tools that they have at the beginning. Of course, it's not a consistently pretty picture. There has been some pitfalls and drawbacks related to availability of personal protective equipments and such. But I would mention a couple of the most noticeable pitfalls that I think are worthy of our attention if we are looking forward to learning from these experiences. First, availability, accuracy, and public trust regarding data. This has been very poorly managed at different times, because in the very beginning, the numbers would reflect the total numbers of positive cases that were received by the government through their PCR tests. And at the beginning, the government was the only mandated body to carry out these PCR tests. So they had protocols, and they were actually looking for the cases. When the number of cases began to increase, not everybody would undergo PCR tests. There were some cost cuts in that regard, and there was a triage process that was happening for who deserved a PCR test, which of course affected the numbers significantly. And then the government decided to allow other players to carry out PCR tests, because they were not allowed in the beginning. The private sector was not allowed to carry out PCR tests. And when it allowed these other players, which was a relatively positive step to go for, the government did not mandate any sort of reporting mechanisms so that they would actually know how many positive cases are you having, how many tests are you carrying out, which meant that the government kind of threw this responsibility on other players. So you have these drive-throughs where you can get COVID tests, university hospitals and private hospitals providing these services in their own labs, but they're not reporting to the government, and the government is not even asking them to report these cases. So the number that we see are numbers that reach the government. These are people who have intentionally decided to seek government services for their lab tests. And when you consider the issue of stigma, when you consider the issue of how it affects people's daily lives, people are not incentivized to report symptoms or even positive results at any given moment. and the opposite actually is happening. So this really affected public trust regarding data, and now it's considered something completely obsolete, to the extent that in a precedent that has that has rarely happened during the past decade, the WHO actually criticized the government's data, and the WHO has been working hand in hand with the government in this throughout time. Just recently, last week, they have been critical of the way the government collects its data. The second issue is when it regards to stakeholder involvement and accountability. The way the healthcare system functions and all public matters function really in Egypt, they're not necessarily promoting this idea of stakeholder involvement and involvement of the different beneficiaries in holding officials accountable. And when we see something that's happening like this in terms of the COVID response, it requires not just a whole of government approach to health, but a whole of country, a whole of community approach to health. This was heavily critical when they began to involve the private sector, because they had time. The runway for the COVID progression in Egypt was pretty late compared to other countries in Europe, for example. So we had the time to respond to that and to prepare a little bit more. And during this time, there has been significant calls to involve the private sector in the discussion, in the conversation, and to involve the doctors through the syndicates in this conversation. This hasn't necessarily happened, and so the conversation would only happen in moments of crisis. When doctors decided to say, that's it, this is not a suitable environment for us to work on, when the syndicate began to become vocal and to begin announcing press conferences where they would denounce the problem that they would have, then the government would sit with them. When the private sector began to get involved and they completely overpriced services for COVID management and treatment, then the government began to hold meetings and to mandate mandatory pricing, which wasn't satisfactory for the private sector. So they simply announced, we are not going to be providing COVID services. Then the government had to retaliate and to try to reach a compromise with them. So now we're in a phase of, you do what you want, but you don't make a big deal out of it. So it's really not the most ideal. Yeah, my son really likes the word compromise. So, so the government actually doesn't really take the idea of social involvement and accountability in the same seriousness as it should have been done. A major problem was transparency regarding resources and needs. Civil society was extremely present since the very beginning, and there was a considerable readiness to step up and really fill the gaps. But the government never actually announced what are the gaps or the effects that were happening. We were seeing very conflicting messages between doctors saying they don't have access to the sufficient PPEs that they need. And on the same day, the government is sending PPEs to the US to cover its defects. So it was extremely confusing for civil society. We didn't know, does the government need more ICU beds? Do they need more ventilators? Or is it just a matter of better allocation of resources and better triage of patients? This has never been very clear, which really affected the community's response and the community's role in that regard. And of course, market regulation was quite effective, especially regarding masks, regarding the availability of the most basic needs for the families during the response. Another debatable issue was the issue of freedom of expression, which is not related to health, but in the end, it affects the whole ecosystem. When you have limited capacity for criticism of government's policies, or for people to actually say what they are seeing, it causes a certain problem in the dynamic between the government and service providers on one hand. And this was heavily translated actually with the arrest of a number of doctors who just said, you know what, we don't have PPEs. Because in the end, it conflicted with the messages that were given by the government. So you can see that in the end, healthcare is it's a big ecosystem that is affected by everything, even things that may not be seen as directly related to it, which really brings the issue of we can't necessarily have a country with a positive response to such a pandemic without looking at the way decisions are being made and the country functions overall. Now, regarding the vaccine in the future, I think I'm going to leave this to discussion, Ayman, no? Yeah.
Yeah, we can leave it to the discussion.
Yes, perfect. So yeah, in conclusion, I just wanted to say that when we look at these things and begin analyzing them, we can then clearly understand that you know, a whole of society and a whole of community approach to healthcare is really what makes the whole difference in that regard. And even if the government has been capable of being flexible and agile and adapting, if the community and society is not on the same page, it really leaves lots of missed opportunities in a way. Thank
Thank
you
you
very
so
much.
much, Ayman, for your presentation. Indeed, important insights, especially on the data availability. Let's call it the data management. Thank you so much.
Thank
Now
you.
I invite Dr. Ridwan Ibrahim. Can you please share your screen? Perfect. Dr. Ridwan, may I ask you to unmute yourself? We cannot hear you. We cannot hear you, Dr. Ridwan.
The research paper, is actually based on the government's decision to ease lockdown phases in Nigeria. I and my colleagues actually look at what are the implications of these government decisions on the healthcare system and the rate of increase in the COVID-19 cases. The background to our study is based on the fact that just like every other countries are adopting lockdown measures as a way of curtailing the increase in COVID-19, the government in Nigeria also did the same thing. After a while, there was this pressure from some business practitioners in the countries that there is need for government to ease the lockdown. And this is actually based on the fact that we are looking at the economic implications of the lockdown. And also, because of that, the government made a turnaround to ease the lockdown of COVID-19 in Nigeria. As the government was planning to make this decision, there were some health practitioners and health organizations that raised concerns that easing lockdown in Nigeria at this point in time, when the country is not ready, might further aggravate the situation in the country. But despite that, the government ahead with the decision to ease the lockdown. Due to this, I and my colleagues, we collaborated together to see what can actually be the effect of this government decision to ease the lockdown. And the aim of the research is to answer the question of whether the country was ready for easing the lockdown or not before embarking on it in the light of the global practice and standard. We actually try to assess the government readiness in easing the lockdown, going by the World Health Organization's standard for countries that needs to be fulfilled before embarking on easing of lockdown. And the first one has to do with transmission control. The WHO advised that there should be a total arrangement on how the transmission of COVID-19 should be controlled, most especially for the ones who are imported from other countries. And we try to assess the government readiness in this aspect. More so in terms of the adequate health capacity, looking at the number of health practitioners that we have, and also looking at the number of hospitals and healthcare centers that are available to curtail the sporadic increase in COVID-19 cases in Nigeria. We actually try to assess the country in that aspect. Also, the ability of the government to minimize the risk was also assessed. The other one has to do with effective preventive measures. That once this is controlled, there is need for prevention of these COVID-19 cases, which is also one of the major goal that we actually embark on. The other one has to do with control of importation risk. That is, for people, because what we have in the country then some form of despite the ban on coming into the country So we actually see how ready is the government. Then on the part of the citizens, there are still a lot of misunderstanding. So people believe that there was nothing like COVID-19, that it is just like it's a cooked up story by the government. So some people did not believe in it, and this is one of the reasons that contributed to the increase in the number of the COVID-19. So we actually assess the country based on this standard, and we found out that there is still much to be done as far as Nigeria is concerned before embarking on the lockdown cases. Now, to look at the impacts, we assess, we base our evidence, our research on daily cases of COVID-19 as produced by the NCDC, that is the Nigerian Disease Control. We see that the first between February 28 and March 29, 2020, Nigeria was in the pre-lockdown stage. There was an increase in the in the number of cases in the country, but this number was still, to an extent, the marginal increase from day-to-day cases are not that as much as at then. But between 30th of March and May 3rd, the lockdown was embarked on. And we actually saw that there was a kind of a gradual reduction in the number of daily cases that are being reported in Nigeria. So when we now look at the lockdown period, that was the easing of, that was between May 19 and July 15, 2020 till now, we saw that the decrease that is being recorded, the success that are being recorded during the lockdown phases became a challenge as the country now began to see a lot of increase in the number of COVID-19 cases then. For example, we observed that on a single day, on the first day of lockdown, this country recorded about 233 cases, 38 cases of COVID-19 then. And the number before then has always been in the two-digit numbers before the easing of lockdown started in Nigeria. So based on this, we felt that the country is not actually ready, and there's need for government to actually reverse the case in easing up the lockdown. In Nigeria, there was about three phases of lockdown. There was the first and there was the third phase of lockdown. In the first phase of lockdown, the country witnessed the additional cases of about 8,673 cases in the first 35 days of the easing up phase of the lockdown, when the country started easing up the lockdown. Then the second phase of the easing up phase of the lockdown, there was an additional number of about 14,712 cases of COVID-19 in Nigeria. And that was just between 29 days. And in the third phase, which is between the country actually witnessed about 9,049 cases in just 16 days. And as at present, the country is within the range of 74,000 cases. So these are the concerns that we actually looked at. And after then, we tried to see what are the implications of this lockdown on the healthcare system. We found out that the first thing is that the country itself, before the COVID-19, the healthcare system is still has a lot of challenge. It's still embattled with poor healthcare infrastructure in the country. There is need for the government to actually increase more funding, investment in the healthcare system. So because of that, looking at this, we felt that the government need to look at the following things. The first one is that there is need for transmission control, which the government failed to look at the inception before embarking on the lockdown. And during this period, the Nigerian Association of Medical Resident Doctors actually embarked on strike, based on the fact that the government actually did not yield to their call to stop the lockdown. So we felt that there is need for government to go back and work majorly on the transmission control as far as the country is concerned. And also there is need for the government to increase capacity, increase test capacity. Because just like Nigeria is the most populous country in Africa, it is very surprising to note that as at July 15, 2020, the capacity of the country in testing COVID-19 is still about 199,016 as at then, compared to South Africa that has a very low population to Nigeria. South Africa then can test about over 2 million tests and 2 million cases. Then as at then, Morocco also can test about 924,000 cases. They have the capacity to test. So Nigeria, which being the most populous nation, has the lowest test capacity as far as the COVID-19 cases is concerned. We felt that there's need for government to increase the test capacity in order to control to curtail the increasing number of COVID-19 in the country. And also, just like I said, we observed earlier that there are some beliefs in the country that there was nothing like COVID-19. So that shows that there is need for government to actually sensitize the people, to sensitize them on the need that this COVID-19 actually exists. And these are some of the things we resolve in our research. And presently, though the country has embarked on a total opening of the economy for about 2 to 3 months ago, but recently there is a rethink from the government. About 2 states, as at 15th of December, about 2 states has embarked on closing up of all schools, considering the number of increase in the country. So we still believe that government still needs to do more as far as looking at the global practices in easing up in opening economy upon lockdown of COVID-19. And this is what we have as far as our research is concerned. Thank you so much.
Thank you so much, Dr. Ridwan Ibrahim, for this interesting presentation. Now we move to our final presentation. Thomas Otten. Thomas will present the case of the US. Thomas, please.
Thanks a lot for this invitation. Give me a second.
Yeah.
Do you see this?
Yes.
Perfect. So, my name is Thomas. I will present to you today what has happened in the United States relating to the coronavirus 19 pandemic within the last year. I'll do that based on 2 articles that I've co-authored, one that I've written with Dr. Savannah Bergquist and Nick Sarich that we've published in the special issue Elsevier, and the other one that I've written only with Dr. Savannah Bergquist and that we've published in the Independent Australia. My presentation will follow the following structure. First, I will talk about the general US COVID-19 statistics. Then I will talk about the pandemic strategy that the US has employed. And lastly, I will focus for a few minutes on the healthcare policy and what impact that has had on especially minorities. So in general, until last Saturday, there have been around 16 million cases recorded of COVID-19, and there have been around 300,000 deaths. This puts the US in first place in terms of absolute recorded deaths and 11th place in terms of recorded deaths per capita. As you can see, there have been 3 waves. We're in the middle of the 3rd wave in the US right now, which begs the question what the US has done to respond to this crisis. So in general, we can say that the policies that the US has employed have been very federalized. This means that while some responsibilities have been have been implemented at the national level, such as economic policies, funding for technology and pharmaceuticals, and travel restrictions for China and for example for Europe. a lot of the responsibilities have been at the state level. That means that, for example, the non-pharmaceutical public health interventions and a lot of the healthcare system responses have been the responsibilities of the federal states. We can see that here with the figure on the left side that we have from the Elsevier special issue, where we have 5 different interventions which are and when they have been implemented in the 50 different states between February and August. And we can see that the responsibility of the federal state has really made a difference in when things have been implemented. For example, Utah, sorry, I'm afraid you can't see it very well, but Utah and Indiana have implemented the state of emergency within the same week. However, the mask mandate have had a difference of up to 3 months between these 2 states. Then I will come to the healthcare policy and what impact there has been with the coverage and how that has showcased the racial inequalities. On a national level, there have been 4 different acts until May, which mainly aimed to extend the coverage and increase healthcare capacity. The first one has been the Coronavirus Preparedness and Response Supplemental Appropriations Act, which extended the telehealth coverage in Medicare and Medicaid so that people who are also not from rural areas could be covered for telehealth. Then there was the Families First Coronavirus Response Act, short FFCRA, which implemented regulations for sick leave and extended coverage for testing so that most people, also the people who are uninsured, would be covered in case they had symptoms. Then there was the CARES Act, which regulates the test pricing between the providers and the payers. There was the, in addition, the CARES Act also provided funding for vaccine development and for buying vaccines from other developers outside of the US. And there has been partial coverage for treatment so that people, also the uninsured, could get treatment in some places. Lastly, there has been the Health Enhancement Act, which regulated the funding for testing and for personal protective equipment for healthcare workers, and also regulated the reimbursement of providers who were foregoing the provision of care. However, there have been 2 holes in this policy, and that is that cost for testing and cost for treatment can still be applied to everyone. This means that some people, even though in theory it should be covered according to the acts that I just talked about, have still been charged for testing by, for example, out of network providers, and have still been charged for treatment because they were not properly insured. While this shouldn't happen, as not all providers are familiar with the acts that have been implemented, people were still charged individually. In addition to that, testing for uninsured and for people who are not symptomatic anymore can also be applied to the to patients. So for example, if your employer requires you to have a negative test before you're coming back to work, and you had a positive test in the past, but you're not symptomatic anymore, these costs may apply to you. This can, of course, disincentivize people to get tested in the first place. In addition to that, people who are uninsured have additional problems with getting their treatment reimbursed. As I said, providers often don't know where to apply to get costs reimbursed, which means that in the first instance, they will have to pay for their treatment. This is, of course, especially problematic because of two reasons. First of all, people are losing their insurance at the moment, which is, because a lot of people are insured through their employer, and minorities are more likely to be or underinsured, which means that they are also bearing the brunt of this problem. This leads me to my last point, and that is that people of color have been bearing the deaths caused by the coronavirus 19 pandemic disproportionately. Here on the left side, again, you see a figure showing that the risk of death of indigenous, Latino, and Black Americans has been much, much higher than that of white or Asian Americans. To illustrate this, while 51 white Americans out of 100,000 have died of the coronavirus, 123 out of 100,000 Black Americans and 133 indigenous Americans have died of the coronavirus 19 pandemic in the past year. The CDC offers the following explanations. First, what I just explained, the healthcare access and utilization. Then a lot of people of color are working in essential occupations, which means that they might have more contact with people, which is a risk factor in itself. Then, of course, socioeconomic inequalities, as these populations are often lower educated, have lower income, lower wealth, and worse housing. And lastly, of course, discrimination. I would like you to take three different things from my presentation. The first one being very objective, that is that the public health response has been very federalized, that on the national level, the economic and technology policies have been implemented, and the state level has had to implement a lot of the public health interventions. Then secondly, that there has been a problematic healthcare response. And lastly, that minorities suffered disproportionately from the pandemic. Then I would like to thank you for your attention. And in case you have any questions, as we have only limited time left, please direct these to my email address here.
Thank you so much, Thomas, for this interesting presentation. I especially like the breakdown by ethnicity. Very insightful indeed. Now we will start our discussion. I would like to invite all the audience. If you have any questions, please write it down in the chat box. I have already one question, and I would like to engage Professor Treta. It's actually maybe a twofold question. So we would like to know more about the impact of inequality and wealth on the capacity of different countries to respond to the pandemic, and perhaps also to the access or the vaccine accessibility. And also the kind of challenges to the collectivism that is supposedly embedded in global health, and the reassertion of new colonial regimes, let's say, and pre-existing power relationships in international relations.
Maybe I could clarify. I guess I think part of what's interesting is this is the first time we're having our discussion after the vaccines have come out. So in some ways, we're entering a new set of regimes. So what we now have is some evidence of differential responses by different kinds of countries. And today we've heard much more about developing countries. My question is really, what happens now? Now the vaccines are out, and what we've seen is the developed countries monopolizing access to these vaccines. So the rich countries have purchased 53% of all the available vaccines. Canada has purchased enough vaccines to inoculate its population 5 times. What this does is reinforce existing inequality between the wealthy countries and the poor countries. And yet, we're in this together. Our risk in the wealthy countries is in part predicated by the risk that everyone else has in the poor countries. So where is the scope for action to mitigate this inequality that we're seeing in the next stage?
Thank you so much.
Yeah, perhaps, Simon, I want to add something to this good observation. I think for me, what is very strange in this vaccine debate is the actual law and economics aspects that are being, once again, a little bit overlooked because of the mechanisms that, formally have to take place when we are in front of a new drug. Obviously, there are a number of aspects here that are not being discussed that I think are fundamental. And the first one is the concept of bilateral negotiation between the developers and potential producers of the drugs, so the vaccines, and the countries. So, and this is the first point. So Jonathan rightly said that there is being a purchasing going on. All right. So this is all good and fine because, in fact, what the countries are purchasing, it's not so much the production, it's the IP. So that is regulated by the trade-related agreement on intellectual property, so-called TRIPS. Those agreements, in fact, do provide that protection. However, they also provide exemption, one of which is actually public health emergencies. If that's the case, then there is a thing called parallel import, which allows countries, for example, to contact Canada and say, hey, Canada, we want to import from you based on your obtained purchase at zero cost or next to it to actually produce the IP or the drug, in this case, the vaccine ourselves. As a generic, like there is a history of this in antiretroviral drugs for HIV in India, in South Africa. You can read the jurisprudence on that. And interestingly enough, because of the nature, and that's point number 2 of the TRIPS agreement, what you have here is a chicken and egg situation. The TRIPS agreement are protection on IP. And therefore, in order for the exemptions to be applied, you need to prove somewhere in some court that, in fact, you are in front of a public health emergency. And literally, this is the protocol that we're following, despite the fact that nearly any regulation on individual freedom, on whatever, has been lifted without much of a court intervention or much questions being asked, right? So that raises for me the second question. Number 1, we're following bilateral negotiations. So who's got money buys it, and that's in line with the TRIPS agreement. Number 2, for those two, the exemption to be activated, we need a court, but we never really went to a court for any other policy to be activated so far, whether those are technology introduction related, protection of mobility, restrictions, even penalties, you name it. We have gone at the country level, supply chain at the international level with, let's say, a pretty active suspension of the norm. Then this leads me to this third point, and it's more like a question. It's really, why is this happening? Of course, then that's a naive question. It's for commercial reasons. Well, if that is the case, then it's not quite clear to me what and how the trade-offs that are in play here, and the one which is mastodontic, which is between the potential cost saving, in fact, of reproducing the IP through a generic pharmaceutical production everywhere in the world. India has a wealth of pharma industry that can produce this and make it available as it has done for decades. So that cost saving versus the profit on something that has been largely subsidized. Let's not forget that the development of vaccines for COVID has been way beyond the 11% that it's typically spent by a nation to subsidize the production of drugs. We typically condone that by repaying for that drugs through our tax system or other public means. Now, here we're talking about a far less important contribution by the private sector to develop these drugs. So I'm not really sure how come this discussion is not out there, apart from the fact that there are big interests involved. But so I just leave it at that.
Thank you, Francesco. Very stimulating indeed. I would like now to come to Ayman Saba. Ayman, since you are an expert on the right to health and the associated, let's say, ethical consideration, I would like you to reflect a little bit on the emerging vaccinations and the ethical aspects in this regard.
Well, thank you very much for this very yeah. I learned a lot today, so that's always something to thank for. So in Egypt, we have had a number of clinical trials that were happening on the new vaccine, and this was part of the solidarity trials that were steered by the WHO. ممكن نخلص؟ Okay. Okay, come here. He wants to join the meeting, my son. He has a day off today. Okay.
Hi.
So, hello. So the thing is, when we look at the clinical trials that were happening in Egypt, it was done in a way diplomatically to pave the way for an early introduction of the vaccine. And it was a very political maneuver, really, because in the end, the trial was done on two vaccines, one from the UAE and the other was from China. And the trials were actually against placebo as well. And they already were planning for 6,000 participants. Eventually, they increased this number significantly. And during this this trial, something very strange actually happened, which is that, you know, they announced the trial on the same day they began to accept participants. Immediately, like on the third day, the Minister of Health was, you know, examining the way the trials are being carried out and everything. And they had already announced, you know, that people are already recovering, and, you know, that immunity has been peaking and everything. And there has been a significant media vibe that is completely non-scientific that was happening, to the extent that it was reported that some people were actually promoting the trial as a way to receive the vaccine, and that this is effective. It has already been effective in the UAE. And so the idea that was that you take part of the trial in order to get the vaccine. Even the announcements of prioritization of people who would receive the vaccine first, this was already being promoted during the trials that were happening. Which was really quite a problem, because we have had reports of people who, you know, took off their mask, claimed that they are immune because they took part of the trial, not even knowing that they might have been part of the third who were receiving the placebo anyways. So here, when it comes to clinical trials in general, Egypt has been working on improving its legislative framework, because the way informed consent is being collected and the way the results and the value of the trials is being promoted has been quite questionable. In an accelerated process, such as the one needed for the production of vaccines for COVID-19, many of these considerations were kind of intentionally disregarded because of this understanding that it will pass, because we're in a crisis and it is not expected from us to actually abide by all of these stipulations. The most basic of them, for example, was that the consent form that was signed by people in the trials in Egypt were referring in some of their clauses to a healthcare coverage scheme that was actually not available in Egypt, because they just took the same consent forms for the UAE participants and they just put it, you know, in the Egyptian context, without even acknowledging the fact that people who are part of the tribe are not covered by private insurance, such as the case in the UAE. So it was a very accelerated process, which raised lots of ethical considerations. A couple of days ago, the Minister of Health went to the airport to receive the first batch of vaccines, which is coming from China. And they have already been announcing that they are beginning its distribution among the priority stakeholders. The medical syndicate is actually holding a press conference likely today to announce that they are going to promote doctors to take part of this priority groups, and that they have trust in the vaccine that is being rolled out. And Egypt really works on superlatives in the way it responds to the pandemic. So they really want to be the first and the best and these sort of things, and they have every intention to do that. So there is here the accountability is not necessarily in front of the people as much as it is for the international community, which is another layer that needs to be put into consideration as well.
Thank you so much, Ayman, for this reflection. I guess we have no questions from the audience. Please, if you have any questions, please write it in the chat box. I will go a little bit up. So I think, and this is a question for Francesco, I think Professor Treta, he observed that Chile is a little bit different than other Latin American countries. Is there a specific reason for this, Francesco?
Yeah, I don't know. Yeah, surely it is different. I'm trying to think about whether it's more different than others, among each other. I suppose that if I had to guess, Chile is clearly historically been always considered the most developed, of the underdeveloped, so-called. I really don't like this terminology, but we do what we can. It's like the next to be OECD, right? I'm even pretty sure that it might even be in OECD at this point, but it's the last somewhat for some of these metrics and indexes. Like certainly from my personal, is any of the countries you have, I think, so that's a different question. So if anything, when you look at the system, which is probably the social security in general, Chile has a clearly much more functional social security system that applies to pension, to healthcare, both insurance and delivery and so on. And also in terms of inequality, the metrics clearly show that compared to Brazil, Argentina, Colombia, in all grounds, it's performing quite well. I would say though that here we are in front of a pandemic really, and so the one aspect that to me surprises me most, it's actually the poor performance of Chile compared to other Latin American countries because of all these reasons. And one even bigger reason, it's geography really. I mean, apart from Santiago, Chile could have prevented entry of COVID like an island almost, like Uruguay did almost, right? So the geography of Chile is what was the strength in a pandemic here, like it was for many other countries that are not so connected like European countries. In fact, the connectivity between Chile and the rest of Latin America, it's sporadic. I mean, there are a bunch of streets and clearly it's all airways and deserts on top, mountains at the bottom and on the side. And we're talking about, similar to these ones on my back, which are the mountains you see from Innsbruck. So like Alpine, the Andes. So for me, Chile is one country that could have done much better in terms of prevention. And the story of this pandemic, in the way it has diffused in Chile, it really came in because of international travelers, typically in the higher income brackets. And now these are the ones that are off the hook. So the inequality, again, plays in strange ways, but certainly, it hasn't been, I think, well thought through, the border control there, to protect some brackets in the population that use more international travel. In this respect, I admire what they've done here in Australia or New Zealand basically they shut the borders, you know, and the problems that we've had, it's because of mismanagement of that border control, which can happen as well, right? But the one other terrible story you might think is, and Jonathan can talk to it better than I can, but certainly also the UK is a big island, right? Or Ireland. The choices there were made for a number of reasons. And let's not forget that the politics of COVID, once we have the patients to look at it and carefully analyze that data, will reveal a lot of interesting and maximization of equations of the political interest that would be hard to comment at this point in time. But now it's all opinion. But I'm very curious to see the literature coming out. It's on my air, so I just speculate at the moment. So I hope this answered the Chile question.
Thank you so much, Francesco, for this. We have a discussion going on in the chat about countries who might require the vaccine as a mandate. It's a mandatory vaccination. And I guess, from my knowledge, it's still a little bit early to observe this. It's still rolling out. But I think Wei has answered that maybe Singapore has taken some steps toward requiring vaccination from all residents and citizens. So I guess we will know more, maybe in the upcoming weeks or upcoming even days. So thank you for this question. I guess we are going over time a little bit, so I will have to conclude this session. I would like to thank the VheP group. I would like to thank Francesco personally and Professor Treta, and those who are not here, Professor Doon Lee and Naomi, for this successful webinar and the successful special issue as well. Thank you so much for contributing to this, and I am sure that in the near future we will find new ways for cooperation. Thank you so much and have a lovely day or evening.
Thank you.
And thank you to all our presenters as well. Thank you.
Very much. Bye-bye.
Thank you. Goodbye.
Bye-bye.